If you want to film anything, that's fine. We'll just have a look. Head forward. If you can't see it, come around. If you want to film, you can. Some people like take films and then they share, so it's up to you whether you want to do that or not. All this is on YouTube, so the problem is with filming is you focus on filming and you're not really watching it, and then everything is on YouTube as well. Okay, yeah. Now, so I'm going to use Callum as a starting point. Okay, then you can have a go. So you're not going to spend drastically too long because obviously we want to be going on to the treatment of. But it's nice just to run through some technique and assessment of. When I assess this sort of area, then I call it a motion testing. I think the physios might call it a pivum and a pavum, if you remember. Do you remember that? I can't remember what it was. It was like passive, accessory, into something else. That's why we say motion test. So let's look at anatomically where we are. Head forward. Now you can see on Callum, one vertebra sticks out. See that? Yep, around here. And if you were to feel your own back of the neck, then you might feel 1 or 2 or 3 vertebrae are quite prominent. So the one that probably is more prominent is known as the vertebra prominens and is more likely C7. However, it could change because you might have 2 or 3 that are prominent. So if you go to the most proximal, if you like, and then palpate and extend and you feel it sort of like disappear, then it's probably C6. And if you go to the most prominent vertebra, which in this case is this one, and it stays where it is in extension and doesn't really do that much, it's probably C7. Yeah. Now, later we will do some more anatomy, but when you bring your head forward, C7 obviously articulates with T1. So between C7 and T1, what nerve root will exit? C8, well done. Okay, so it'll be the C8 nerve root, and C8 with T1 becomes what nerve? What nerve? The ulnar. Okay, so the ulnar nerve. So if you have a problem, where might you get symptoms if you've got a problem with the ulnar nerve? Okay, more likely to the distal finger, the little finger in here. Yeah, and the ulnar border around that sort of area. So if you've got tingling that area, you might want to be almost like starting here. Okay, but we'll come to that later on. Now, when we test it, I will use his head as a lever and I will flex and extend passively. My finger is going to go into spine. So where C7 is not going to be on the spinous process of C7. It's going to go into spinous between C7 and T1. Lightly, no thumbs, no elbows, okay, as light as you can, almost like he's not even feeling the contact. If you want to, close your eyes, and so you focus in on whether it moves or not. When it opens, the 2 spinous process separate, so you should feel space. When you extend, it closes, okay? But you don't know whether it moves or not because you've got nothing to compare it against. So you try C7, T1, T1, T2, T2, T3, etc. When you get below T3, we cannot really use the neck as the lever, so then we would use, interlock your fingers behind your neck, please, like this. Allow the elbows to come forward. We palpate the spinous process, whatever level, and then we can start an extension, and then we passively take them into flexion, and then we extend. As you're assessing, you are treating. Okay, so as I am assessing, I am mobilizing his spine already without even thinking about it. Okay, so I am assessing and treating at the same time. So if you do it 5, 10 times, you've mobilized the spine 10 times. Now, let's start with this area in here. So head forward, C7 and T1. Look at spinous process of C7. Look at the spinous process of T1. The gap in there is not particularly great. Okay, so my finger is not really separate between the 2 bones. So I'm thinking C7, T1 feels a bit restricted to me. okay, because there's not much motion here. In terms of distance, if you roughly work on a centimeter between, that would give you an idea, okay, but it's comparative to one below and a one above.
Could you try?
Stop. So from here, so I will motion test as far as I comfortably can, and I will extend. So then I'm thinking that doesn't feel that much motion, so then I'll go below that in T1 and T2. T1, T2 moves a little bit more than C7 and T1. I'm going to go to T2 and T3. T2, T3 moves the same as T1 and T2. So now I'm still thinking C7, T1 doesn't move that well in here, okay? So I've got an idea. So I'm thinking already through motion testing, C7, T1 doesn't move as well as T1 and T2 and T2 and T3. So I'm going to focus my effort on that C7, T1. So I've got an idea. So, okay, as an example, if C7, T1 doesn't want to open, it's probably going to be fixed closed. And it's either going to be closed on the left or on the right. It can be closed on both. When we do the treatment later, it's not a positional manipulation. It is a manipulative technique of C7 on T1. So if it's fixed on the left, it opens. If it's fixed on the right, it opens. It's not I find the neck and I side feel for the position and then I adjust. This is just simply a lift to gap. Okay, but it's nice in your notes to say, I believe through testing, it's on the left. Okay, yeah, rather than just saying, I think it's closed between C7 and T1. I said it's on the left. So it's ERS left, closed left. So let's run through that test. So now from here, so from motion testing, we would then come around like the pictures with your thumbs. So now I'm coming around, we can't see, come around. So from this position, with his head forward, let's say we start in flexion. He did say to me, Callum has a slight scoliosis and it doesn't bother him. So with a scoliosis, it will be more likely a type 1 dysfunctional, okay, because it'll be a group dysfunction. So normally when you have a scoliosis and you bend forward, you might have a high side. So it's called a rotoscoliosis. So it's a group dysfunction. So as you side bend, say left, the rib cage is pushed to the right. So you have a higher side. Yep. So let's just run through this anyway. Okay, so we got C7. And I'm saying C7, T1 feels like it's not doing that much. Okay, so from here, if I brought my thumbs lateral, okay, I know the scoliosis is going to affect it a bit more, but we'll just run through this assessment here. When I bring my thumbs over and down, it is probably quite obvious which one is deeper and which one is shallow. What do you think? The right is deeper, the left is shallow. Okay, because he's in flexion, the left side is shallow and the right side is deep. Teresa? Yeah, what do you think?
So I think it's closed on the left.
Well done. Okay. Okay. So the key one is flexion. You're looking for a shallow side. So anything in flexion, shallow side closed. Okay, you can almost like do one in flexion and just think which one is shallow. Okay, and it gives you an idea then. Now, if I said come to neutral and I palpate, okay, it's still deep on the right. And if I asked him to extend and I come in, the problem is because it is a change of a scoliosis, okay, it's not going to change that much for this dysfunction. But from here, if I was to say incorrectly that my thumbs are now level, and as he goes into flexion, my thumb is now shallow on the left and deep on the right, it would have found a type 2 dysfunction closed on the left. But with a scoliosis, it's fixed in a type 1. So the side bending and the rotation will be to the opposite side. So it'll be side bend, say, to the right and rotate it to the left. But we will leave that alone because it's a bit more complex. Okay? So that's what I would be looking for. Yeah, around here. So motion test, flex, extend. Think, which one do you think is moving less than the other? If you want to go further down, you can. Interlock your fingers. But maybe just stick around the lower part of the cervical, the upper part of the thorax, as we are doing it. But as you are assessing, maybe just have an awareness, because we are going to move down to the thoracic spine, and think, do you feel one a bit lower? Okay? And if the answer is yes, maintain the pressure on the finger, let's say here, come over to that level. Okay, so we got the inferior angle is in line with what? T7. Spine of the scapula is in line with what? Stop it. Okay, but T3. Okay, so we can roughly work out where we are. So if I said it was more here, so we got T7, T6, and T5. Okay, in that sort of area. Palpate the level. Okay, and you think, well, nothing's going on in neutral there. If you ask him to extend, and let's say for instance, in this case, he extends and there's a deep side on the right. And as he flexes, okay, it becomes level. We think it was level inflection, but as he extends, there's a deep side on the right. So it means that the right side doesn't want to close, so it's fixed open. Okay, but the vertebra will be rotated to the left. So it'll be an FRS to the left, but the right side is fixed open. Okay, right. So that's what I'd like you to do. So maybe you don't really need much stuff on the couch. You can have, I think we're almost like 2 or 3 on a couch. We got an extra couch, so split yourselves out. I'll walk around and guide you. So we're not going to spend too long. So motion test. See if you can find something, and then swap over. Okay, ladies, you don't need to expose anything. Okay, so you can just pull your t-shirt down a little bit, and then palpate that sort of C7, T1 area.
Start whilst I'm in. You can try me whilst I'm
Do you want to take your books with you, or? Yeah, otherwise.
I'll throw it over there.
Yeah.
Away.
I'll take out a lumber. You don't actually need to sit on the couch. You can actually sit on the stool as well, because it's quite nice for the patient to be a bit lower. Yeah, like the stool is quite nice. So I guess high, isn't it?
That's all right.
But yeah.
We'll change it after.
Yeah, no, that's all right. Yeah, sometimes to sit in the chair is okay. So you can almost like, yeah, you sit in a chair because that brings you lower. Yeah, and it's actually quite nice. Yeah. Oh, it's nice and warm in this corner.
I know.
No, it's too hot. Well, yeah. What's your training, Doug?
Sorry?
What are you trained in? Sports therapist.
Yeah.
Okay.
Right, so
if you bring the head forward,
yeah,
then you can find there's a couple of bumps. Yeah.
Okay.
Around there. So obviously the most prominent is probably C7 and T1. And then just look at the spine and the spine and look at the gap between them.
Yeah.
And then look at the next one and think, is that gap a bit more than that gap?
Yeah.
And then maybe lightly you can then do some motion testing to think, does it want to open? Go to the next one, does that want to open? And you think, oh, I think that one's a bit stiffer. Then bring your thumbs across and just think, is it a shallow deep side? Yeah, and if it's a shallow side inflection, it's closed. Okay? I'll work on that. It's probably easier, rather than being that position, if you ask her to turn around, so she's sitting that way, then rather than you being there, now you just been here. And sometimes it's even better in a chair because they are lower. If the couch is a bit high like there, but if they like sitting in a chair, you'd almost straight over them. Yeah. The problem is when you hit in here, it's easy to be a little higher. So try that one. Yeah. Okay. Have a go. Huh?
No offense, John. I don't mean that to you.
No. Yeah, you do. Yeah. If you're not sure, speak up and I can help you. Like some people, you can see easy each spine, the gap between each one. You know what I mean? So it's nice. Yeah. Remember, as you're assessing, you're already treating. So if you do it 10 times, you do it 10 times. By the time I come to it, I'll be like, I'm not feeling that much because you're mobilizing it. You're moving it. Yeah. Yeah. C7.
C7.
C7, T1.
C7, T1.
Yeah. I know you didn't see it, Callum. You okay?
Yeah.
Rather than using your thumb,
Finger.
lightly like this. Okay? So less
Get
is
in
best.
between.
And then try to go, find head forward, find the spinous process. Okay? And then just go in between lightly and just think what the gap is like in here, what the gap is like in there. Yeah, and then from there, and you just motion test him gently. Your hands are freezing, mate. Yeah, and then you can just feel how much motion,
It's going through.
how much motion. Again, just think, is there one is a little bit stiffer than the other? Yeah. Okay. And even like with your eyes closed, where you just focus in,
Yeah.
can help you. It's hot in here.
It's not warm at all.
Yeah, his hands are freezing. Yeah, I'm not quite warm. Oh, you're yeah. You're not so bad.
Sorry, Kelsey.
Yeah. Sometimes it's easier when it's lower because you're almost there. I mean, you can almost
Yeah.
like feel and see things quite easier rather than being higher. The problem is thoracic spine because it's probably too low.
I know, so they are.
Uh-huh. Yes, mate. Yes.
You see, I did those a bit of assessment, but I think that when they go in extension,
Yeah.
well, some of the the trapezius and rhomboids they contract more, and I feel different.
Yes,
So in
it
terms
is.
of assessment, when you go in extension,
When you're in an extension, you almost have to, because if you just extend and hold, the muscles now are tight.
yeah.
You almost need to try to extend and try to let yourself relax a bit. Do
Okay,
you know what I mean? Where the muscles now
okay.
relax and the thumbs can sink in.
Thank you.
No worries.
You can go.
Okay.
Okay, moving forward again.
You're looking for inflection. Is there like a shallow side?
Yeah.
Yeah.
This feels deeper here.
Okay. Looks like it's deeper.
Yeah.
Okay. Okay. So that's deeper inflection. Then obviously the left side is fixed. So C7 is fixed closed on the left. Yeah. Okay. Good. Well done. Yes. No worries.
Right went deeper.
So you
So my right was deeper.
Okay.
When I flexed, my right went.
Even more deeper. Okay. So it means the left side. So inflection. So inflection.
Remember to do it again, just like if you
Right
were
side deep, left side shallow, yeah? So that means that inflection, the side that's shallow, the left side is closed because it doesn't want to open. That's what you're looking for. So even though the right side is deeper, it's basically,
So
it'll be the left side is shallow, so it'll be closed left.
okay,
Yeah.
so
So it'll be ERS left.
that again then. So
Yeah, so for instance, if you bring your head forward, okay, so you find, say, stays you are, so C7. Okay, so C7, T1 is not much of a gap, okay, so it's a bit stiff there.
yeah,
Yeah.
down on T1.
T1, T2 is fine.
Right.
Yeah, so that gap there is better than C7, T1. So C7, T1, I think is stiffer on that one, okay? So C7, T1, so bring your thumbs right, yeah. Right side goes deeper than left side is shallow. So inflection, left side shallow, right side deep. So the left side is fixed closed. Because inflection, they should both open. If the side that's closed doesn't open, it stays back. Okay? Yeah, so C71, ERS left. Yeah? Good. Well done. You understand it?
hang on, I do tell you in case you put my hand
Yeah.
on.
It's almost like looking at, rather than looking at it as free, just almost like just do it in one. Do you know what I mean? So you just do that bit and that bit. Try rather than thumb. Okay, so head forward, find a vertebra, find the other vertebra, go in between spinous process, so into spine, yeah? And then just think, is there much movement in that one? If you're not sure, go to one below, and then just try that one. Does one move a little bit more compared to one moves a bit less?
Yeah, I think that one moves more than.
Okay. Okay, so again, same as you went, C71. So then if it's not open, then it must be closed, either left or either right. So now you're going to do the thumbs either side and look at the thumbs. In neutral, you might not see that much. The key really is get the hip to flex. Is there a shallow side now? Because you're only looking, does this one go in further and this one stays back, or does this one go in and this one stays back?
It's because this is deeper, so this is shallower.
Okay, so he's opposite to you. So if that's deep and that's shallow, because you're asking him to flex, if it doesn't want to open, it must be closed on the shallow
Where I
side.
get closed, and it's stuck here. It's not
Stuck-
opening.
yes, it's not opening. Okay, so it's closed on the right. Yeah. Okay,
If
so
I get him to extend,
to extend, okay, and extend. The problem is with extension is because he
That's it.
uses his muscles to extend, they're going to contract. And when they contract, sometimes it gives you a false positive because the muscles are now activated.
so would you just therefore just look at neutral
Well,
and look at flexion?
you'd almost want him to extend, but try to relax. All right?
And that almost
and-
feels like it's neutralizing.
Okay, good. So that means then, if it's neutral in extension, they're happy to close. Then when you ask him to flex, this side says shallow, this side goes deep, so this side doesn't want to open, so this side's closed.
Okay.
Yeah.
Okay.
Everybody okay? Because you're going to move on shortly. How are you getting on? Or are you just okay? All right. Jerry?
I think the principles.
Yeah. Almost trying to keep it simple, really. You know, if you
so
ask him to
bring it in.
flex, yeah. So
Flex.
just fine because it's fine to bumps easy.
Yeah.
Okay. Yeah, the spinous processes in here. So
Assess the space. Like you
Yeah.
did before.
yeah, so there is motion between C7 and T1, but I think T1-2 is probably a bit more motion than C7 T1. Okay, so this one feels a bit stiffer than the one below. And then while she's in flexion, you know it's a bit stiff. Is it shallow right or shallow left? Shallow left. So left side is fixed closed. Okay, because there's a shallow side here. And this side goes deep. So this side wants to open, this side doesn't. So in flexion, which side is shallow? Left side. So left side must be closed. Okay, if you wanted to test a neutral in extension, you can. But you don't always have to do that.
And if it goes deep in that side, then it's fixed open.
Yes. Yeah.
The principles are fine, but the tactile side.
Yeah. It's very subtle motion testing. Yeah. Everybody okay? If you wanted to work as a 2, you can after. Yeah, because there's a 3 at the back as well. So it's up to you. Yeah, you know, if you find it easier, because you get more practice with 2. Yeah.
So, in here,
Okay, a few minutes. I'm going to move on. Yes, mate.
So you're doing passive movements when you're checking which levels.
Well, no, you can do active. So I can get you to do it.
Oh, okay. Yeah.
Yeah, if you wanted to.
yeah,
Yeah.
I'm going to check from T4 lower.
Yeah. So you can get him to flex if you want to. It's probably easier to interlock your fingers behind your neck.
Yeah, and we did this.
Yeah, and then you can do it. Yeah.
So we do passive. So, or we just ask him.
The thing is with passive is that the muscles are not involved so much.
All right.
With active, it means he contracts.
It's better passive.
Yeah.
And then when you're holding either side,
Yeah.
that'll have to be active.
It'll have to be active. Yeah, it'll have to be active. Unless you change it, unless you're doing say that, and then I control your head. Yeah. But then that's not so tactile as that.
Yeah.
Yeah. Because you're looking. Because when you look in,
You can see.
you're looking
yeah.
left and right. Whereas when the thumbs, you're like, you feel and you're not really sure if it's left or right. Do you know what I mean?
Yeah.
Yeah. It's not my one. Yeah. My books are going down slowly.
Let's carry down the stairs later, John. That'd be good.
I've already took one box down. And obviously all the notes I've given,
Yes.
so that's a bit less.
Be a lot less.
Yeah. I bought 10 towels with me. Huh? I didn't need to bring them because you probably got them. Yeah, mobs. That's what I mean. The stuff I bring is like, it's just madness. I don't really need to, but I thought, well, it just makes the learning experience better.
Yeah, it does.
Yeah.
Just a lot.
Mm.
Do you not leave stuff in Swinton?
No. No. I don't really take how much to Swindon. No? I take in my box of spiny bits and notes, but she's got all the couches and a skeleton, so I don't really need that much.
Right. So it's not as much.
No. Because I'm here for a few days. Yeah. Like the K-tip books I brought, thinking because I need quite a few for you as student, for those podiatrists.
Toilet, turn your mic off. Leave your mic there.
I don't tend to go to the toilet much. Only middle of the night. Because my age. Okay, can I move on? Yes.
I'm not sure it's giving me correct.
No, it's different.
readings after
Yeah,
all.
yeah. So we have to be careful when we treat them later.
Yeah.
Yeah, because it'll be type 1. Yeah, so
Yeah.
the side bend and rotation.
Yeah.
Yeah. So if you just flex forward, does it cause you any symptoms? Are you okay?
I can up above and below.
Yeah.
I could,
Yeah, because with scoliosis, sometimes I don't tend to manipulate too much in this bit. Sometimes I might do above it here, yeah, and I might do below it. But you have to be a bit careful because you might send them down a path.
So, because it kept changing. Like,
It will change.
and it's just like so.
Yeah. Yeah.
Yeah.
Yeah, if you slump forward as far as you can. Yeah. Yeah, this is the higher side. So it'll be side bend and left rotation to the right. And that's type 1 mechanics. Yeah, and, do you know the angle?
I don't.
Okay.
I don't know. I think it's definitely. It's gotten more over the last maybe 3-4 years. I think.
Yeah.
So,
Yeah. It'd be interesting to know.
Yeah.
Yeah, but then it doesn't cause you too many symptoms, and it's just one. Yeah. 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 But be careful when you manipulate them. I'm not sure how I do that much. Yep. Okay, can I move on? Yep.
We're in a debate.
Okay, because she is a pivot around C6 anyway. Yeah, in here. So potentially there could be some symptoms around this area. Do you get any symptoms here or not?
Yeah.
Yeah.
There's symptoms everywhere.
Yeah. So move the head forward. Right side of it shallow, left side a bit deeper. Yep. So C7, T1 feels a bit stiff. Yeah. The right side shallow, left side. So right side will be closed. So ERS right. What did you find?
I think the opposite.
Okay. Yeah, but we bring your thumbs about an inch or 2.5 centimeter and just let the thumbs sink. Right side deep, right side deeper. Right side shallow, left side deep. So because she's in flexion, it is the right side that doesn't want to open.
So I felt completely different. So,
Yeah. Sometimes it depends on where the thumbs are. If your thumbs are closer, you need to be a little bit wider towards the transverse process. Okay?
Yeah.
Yeah, that's what I would do. But she looks a bit stiff just on there.
Okay. So
Was that?
I feel a bit stuck.
Yeah, but we'll be treating it shortly. Yeah.
Commissioning it, applying there when you're coming out. I was trying to go quite.
Yeah, not like that.
So nothing.
Yeah, hardly anything.
Like, 'cause I totally didn't see what you saw on Wendy. I don't know
Yeah.
whether you were hypothesising that was, but
Yeah.
I know it's skill and you need to learn it, but it was just to see if it was a.
Yeah, you don't be doing. It's not. Yeah, it's like pressure. It's an awareness because you're not going to feel the transverse process of the facet. It's an awareness of the position.
Okay.
Okay. You're not going to be physically on what you think you're on.
Uh-huh.
Okay. And I'm almost sarcastic when I say it to my students. I say, "What you think you're on, you're not." So, John, I'm on the L5 transverse process.
No,
you're not.
Yeah,
Okay.
I get that.
It's an awareness. It's an awareness. It's an awareness for the position.
Okay.
And if it's symmetrical, it should be fine. If you see asymmetry, then you know there's a rotation. Yeah.
Right. Okay, that's all fine. I get that. That just explains it.
Yeah.
Everything we're talking about there.
Yeah. And hopefully now when we treat, it makes more sense. Evelyn, can I use? It is Evelyn.
Yes.
Can I use you? Okay. Can I move on, please? Do you want to come round? Do you want to come round? So now we're going to move on to the treatment of. Everybody see? Everybody okay? Right. I think some of you, when I've walked around, you've noticed that C7T1 feels a bit stiff. Okay. Now, C7T1 doesn't normally give you too many symptoms as such. The symptoms are normally above it in the lower part of the cervical spine because it's compensation for. So when we manipulate later this area, it can actually improve cervical rotation. Okay? Because when we rotate to the left and when we rotate to the right, the cervical spine rotates down to about T3, T4. So if C7, T1 doesn't move very well, so it's fixed from there down, it means it's only moving above. Where does the majority of motion come from in the cervical spine? What was that? The AA joint. So the atlas on the axis. C1 sits on the peg of C2. Rotation. Okay, so 50% of the motion, okay, which is around, so if you've got 80 degrees of rotation left, 50%, 40 degrees will come from the AA, C1 on C2, the atlantoaxial joint. The other 50% comes from C2 to 3, 3 to 4, all the way down to T4. So if the top part of the neck is fixated, the bottom part of the neck is fixated, the only bit that's moving is the middle bit, and you wonder why disc pathology, facet joint spondylosis occurs C4, 5, 5, 6, 6, 7. So when I treat necks, I don't always manipulate 4s and 5s and 5s and 6s. I will do this one, which we'll do later, and I will do the one above. And that seems to work for me. Okay? Because the C4, 5 has a disc problem, and you manipulate it, you can actually make it worse. Okay, so I try to offload it rather than irritate it. Now, when we are manipulating or treatment of C71, from a MOB perspective, because some of you are a little bit nervous already, which is fine because it's normal. So let's say, for instance, for the demonstration, that the right side is closed, okay, between C7 and T1. So I'll be on this side of my patient. If it's fixated on this side, I'll be on the other side. But for the demo, I'm just going to do it this way. So when we mobilize a joint, we have to fixate the one below. So if we mobilize C7, T1, we fix T1. When we mobilize T4, 5, we fixate T5. Because otherwise, if I just literally flex my patient and extend my patient, it does not mean C7, T1 is going to articulate and mobilize. The one below it, which is compensating, becomes even more mobile. So it becomes hypermobile, and the one that's hypomobile stays hypomobile. Okay, so when we fix, we can use the finger or the ulnar border here or the pisiform. So we can almost lock down that vertebra. So just a simple movement, okay, if we go to C7 and T1, just a simple placement of a finger going caudally towards the cauda equina. Okay, so I'm locking it down. Okay, and I simply just lock and flex. I am articulating C7 on T1. If you don't like the pressure on the finger, use the ulnar side or the pisiform, and you just mobilize it. And that would be a technique in itself. However, if it's fixated on the right, it is probably better to encourage rotation and flexion to the left to open the fixed side. So rather than just flex in, we can add in a rotation and a side bending left to open the right. So we can lock down and encourage that mobility. Now, an MET from here. Slowly push your head back into my fingers. So she is closing to the right. She is pushing back to the right. 10 seconds. Relax. We have a window of opportunity of 25 seconds to take the joint to the new position by releasing the muscle. Take a breath in. We lock. We take it into that new position and we hold. And then we can repeat 3 times. So what I'm trying to do is open the facet between C7 and T1 on the right by using an MET. Slowly push back again, please. 10, 9, 8, 10 seconds later. It's the PIR method, post-isometric relaxation. Relax, breathe in. And as she breathes out, I then flex her to the left. So that would be a very simple, gentle mobilization. You okay?
So can I ask, when you would have assessed me,
Yes.
that right side would have
Right
been
side.
shallow on flexion.
Yes, inflection.
So it's closed. So that's why you work
Exactly.
on the
Yeah. Go to the opposite side.
away to
Yes.
the opposite side.
So you would just repeat that until you felt a reasonable release.
Yeah, you're not going to get a cavitation on that technique. Okay, it's not going to go click. Okay, and then the cavitation is a release of a mixture of gas, okay, from the synovial membrane. Okay, so like the thumb joint, if you did that, there's a quick release of the gas from there. That's what they consider happens when you cavitate. But when I teach you the manipulation after, I'll explain on how we would do that. okay, where we try to, because it's all about the speed of execution. We cannot, it's like when you've got a chest to draw and you try to get a pair of socks out and you pull it, it gets stuck. And you think, well, what do I do? You've got the sports therapy mobilizing way. You push it back in and you pull it back out. And you push it back in and you pull it back out. A grade 1 mobilization is a gentle push in, pull out. A grade 2 is a bit more, grade 3 is a bit more. Grade 4 is quite firm in, firm out. Okay, you're quite mobilizing with firmness. Whereas a grade 5, it's not pushing away from the barrier. A HVT, a high velocity thrust, is at the barrier. So when you feel the bind, you don't go back in, you pull, and then from there, we pull quickly to try to break the seal. But then that speed has to be very fast, but the distance has to be very small. So it's a high velocity thrust with a low amplitude. Okay, if you pull the chest to draw too much, it comes out and falls to the floor. If you pull the chest to draw too slow, nothing really happens, and the whole chest to draw comes with you. Okay, so you have to have a skill, which takes a long time to learn. I always say when you've done about 10,000, you'll be relatively average. Okay, I'm not lying. Yeah, so when you've done about 20 to 30 to 40, okay, yeah, you're sort of like on the way. Okay, so, you know, and then if I did you a neck and you a neck and you a neck and you a neck, it might look similar, but it'll be different. Okay, when you're doing it. So it's, you know, it's, I will make it look easy when I come to it, but I should make it look easy because I've done quite a few. Yeah, 100,000 plus, if not more. All right, so, but it's, and sometimes my speed of execution, my slow speed is faster than most people's speed, my slow speed. Okay, but, and you have to learn that. Okay, but I'll teach you that as we come to it. Now, if you want to do the mid-thoracic, interlock your fingers, please, like this. Awesome. Yeah, but that's one way of doing it. I'll show you another way. No, you're okay. So from here, let's say, for instance, it's around T7. So ladies with a bra strap, around that sort of T7, T8 area. And again, you think it's on the right. If it's on the left, I'll turn around. So from here, I'm going to, rather than use my finger now, I'm going to use my heel of hand. So I will flex her down, okay, until I feel motion in my heel of hand. So I flex her until I feel it's moving now. From here, I can say to my patient, slowly pull back, please. So she is trying to extend, not much effort, just a little bit of extension. After the 10 seconds, relax, take a breath in. And as she breathes out, a little bit of flexion, a little bit of rotation left, a little bit of side bending left to open that right side. But I could literally do this, okay? I could mobilize. 1, 2, 3. Okay, so I'm just encouraging mobilizing to the left. Look at this next technique here, okay? This is just general stuff, and I like it, okay? Because if I said mobilize the thoracic spine, and you're a sports massage therapist, you would naturally ask your patient to lay on their front, prone, and you'd mobilize them in a prone position. Not many therapists would mobilize the thoracic spine sitting like this. Look at my hand. We can side bend. What happens to the facets on the right? They're opening. Facets on the left are. So this would be a general technique, see? Okay, so I can side bend or side shift. I can flex my patient to open. I can extend to encourage closure, see? Heel of hand, and I can encourage closure. I can encourage side bending. I can encourage, look at my heel, rotation. Sometimes this clicks, depending. Okay, so I can guide her into rotation. I can come down towards the lumbar if I want to. So this is just general. When I do the other side, I will move my patient around. Okay, this is quite a nice little simple technique to encourage a mobilizing of the spine. And it's quite nice to have it done. Okay, all right? Relax. So maybe try them. So that's all I've done. I've done an MET for the C7, T1, and I've done an MET for, say, T7 and T8. And I've just shown you a few little variations of mobilization. The patient, they come to you, okay? I always suggest that they come to you. You never go to them, ever. Okay, you never be reaching, okay, oh, my back, okay, get them right over, okay? So they sit right on the edge. So you literally just, you are there. Okay, for a man, for a woman, it's not so bad. For a woman, for a man, you might want pillow, yeah, to separate between you and them, okay, just give you a bit more privacy, etc.
What was the other hand position? Because I did that and you said no.
Yeah, so the other one, so if you don't like this one, because it can force the neck into flexion, they can literally just do this, and then you come over them. Same positioning from here. Side bending. Rotation. Heel hand. So you go with the motion. Okay, extension is not so easy, but I can just modify my position in from there. Okay, and then flexion, I would guide it into flexion. Okay, so it's just a general mobility exercise for the thoracic spine, because the next phase will be, I've got some towels, we can be rolling the towel, and then we will be performing the mobilizing stroke manipulative technique. So what you can do in a towel when we start forcing, if we cross the barrier of a force and we use the word thrust, it is now a manip. Okay, if we're not thrusting or forcing, it is a mob. So you are safer to use a mob than you are to use a manip, because with a mob they have some control, whereas with a manip they don't, because it's outside what they can stop. Okay, because you are using force push to change the position. We'll see how we get on shortly. That's where the fun starts. Cool. Can you have a go? Thank you, Evelyn. be too close.
Yeah, so it's
Okay.
fixed. Oh,
No. If it's symmetrical in extension, it means the thumbs are level, so
yeah,
they
they're happy to make
close.
their closer.
But in flexion, if there's a shallow side,
Yeah.
it means it doesn't open on the shallow side, so it'll be fixed open on the left.
Isn't that what I just said?
No,
What did I say? Fixed open on the right.
you said open, but it's actually fixed closed on the left, isn't it?
It's staying shallow.
Yeah, if it stays, so in flexion, almost keep it simple. In flexion, if there's a shallow side,
Yeah.
okay, let's say there's a shallow side right, that's closed. If there's a shallow side left, that's
Yes.
closed. Okay,
Yes.
Whereas
That's actually what I wrote down the
Yeah.
first time.
there you go.
So it's ERS to the left.
ERS to the left. Yeah, good. Everybody okay? That's good. Well done. Yeah, couch a bit low for you because you're taller.
No.
Yeah, that's all right. Was it okay? Was it all right?
If you just run through the pulse isometric one again.
Yeah. So let's say, for instance, we got a fixation on the right, okay?
Yeah.
Use your heel hand or finger on the level below. So you use it, so let's say on T1, and then from there, or T2. So then you rotate and flex down until you feel a bind, okay? Until you feel tension down to the level. Ask your patient to slowly push your head back. Okay, so she is trying to go back into the dysfunction. After the 10 seconds, relax, breathe. And as she breathes out, you stabilize here. So this stays. And then you can either go into the new position or you can mobilize into the position. Okay? If it's on the left side, there's no hassle to go that way and lock. Rather than keeping turning the patient around, it would be okay to do that. But when it comes into the thoracic spine, it's easier to treat the opposite side to where she is sitting. Okay, and then you'd use the lever of the arm, okay, to rotate and extend. You okay? You two okay? Yeah. Someone smells lovely. Is that you? Was it him? What is that perfume?
It's oh my god, can't even think of the name, but it'll come back to me.
Okay. It's very nice. Very nice. We'll do some more practice in a second. Are you okay, Nat?
Yeah.
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 Okay, a couple of minutes. We're going to be moving on. You two okay? Yeah. You two friends, or we just met each other today? Okay. Where do you live?
Huntley, Aberdeenshire.
Oh, okay. Oh, it's a few people yesterday from Aberdeenshire.
Yeah.
Yeah, no, it's loads actually. In fact,
Blair's from Elgin.
she's
from
she's from near there.
Aberdeenshire. Louise is from Elgin.
Not sure where Teresa's from. She did say, but I can't remember now. Because I taught in Perth a few years ago.
That's right. Well,
And it was-
yeah.
All right. Okay.
At a
Yeah.
big conference.
It's huge, isn't it? It's like
Yeah.
100 and it's way too many. It's way too many. I know, but to learn, or it's like I'm not sure you can learn when there's that many. You could
The
learn.
Nerval day was good.
Oh yeah, it was about 60, wasn't it?
Full classroom, yeah.
Yeah. It was, well, it was still 60.
Still packed. It was good.
Yeah.
Enjoyed it.
Yeah, whereas people think 20 is busy, but 20 is my max really on this sort of course. Yeah, because it was 18 when I had 2 extra girls who came from Stranraer.
Swindon, but it was Blair that told me a few weeks ago that you were coming up here so fast.
Yeah, makes sense, doesn't it? Yeah, but then the drive for me was easy because it took me 6 hours, no traffic, and it was straight, and it was easy. I was like amazed.
No, I got caught last night with a bad accident on the M8.
Yeah.
And I was doing really well. I was only 20 miles away, and I was stuck for 3 hours at 20 miles away.
Oh, really? Oh,
Sat there,
that's a bit annoying.
shut the entire motorway down.
Yeah.
It's all right. Quick run home, it was about 2.5 hours ago.
Okay. Oh, cool. Okay. All right. So we're going to move on now to the manipulative bit. Kelsey, can I use you? If you don't mind. You'd be pleased to know you can leave. Yeah, maybe just one layer. Right, we're going to use a towel next. Now, Kelsey, can you come and sit here? So we're going to move on to the manipulative side, but you can modify this technique to be almost like a mobilizing, okay? Now, Everything's almost against you for this bit, because if there's no facet restriction and you go to treat it, there's not going to be any cavitation. If a towel is too soft, it's going to absorb all your effort when you go into it, okay? If the speed of execution is too slow, okay, so if you do happen to get a cavitation, you should be proud of yourself, but it physically happened, okay? It's like a 9-stage or 10-stage process. I will show you all the processes, but even little things like the height of the couches, this is low, it's be too low for me now to that one. So this one's probably about right. So, you almost have to adapt it to the height of you. Most of you might have electric hydraulic couch. So using the towel, this is almost one of the key elements. If you don't use a towel, because more than likely I could probably get Kelsey to stand, I could bear hug her if you like and do a little technique and probably something will click. But I don't know what level, and I'm sort of guessing and I'm hoping something goes. Yep. But in my notes, I'll be like, I manipulate the thoracic spine, but I wouldn't say it was a 4, 5, 5, 6, 6, 7. Whereas the towel, when you fold it, so a simple hand towel, you fold it and you roll it as tight as you can get it. You don't have to use all of it, just half of it, but it has to be firm. Okay, it has to be firm. Otherwise, when you pull the patient to you, there's a pressure here. If it's too soft, it's absorbed. A lot of people use the towel. Some people will modify and use something like bin bags. You go by Sainsbury's, buy a pack of 10, it's too firm. People use like a pipe warmer or something. I'm like, I got no idea, but a towel is probably the best way. The towel you have in the clinic that you are going to bin because it feels quite sodden with oil, keep it. Okay? Whereas the new towels that you've washed and tumble dry, they are too soft. So if you've got one that's got a slight dampness to it, even though you've washed it, I would suggest you keep it. Okay, it'll be like your manipulative towel. Now, for woman, it's obviously a bit different from a man for obvious reasons here. Okay, so some ladies, because of the extra, okay, you might find you have to adapt it. Some will come under, some will come over, some will come like this. But for men, it's probably a bit easier, okay, to do this technique. But either way, this is how we would do it. So this towel is placed in the sternum, and then that will go to the level below. So let's say in this case, I'm going to manipulate T6 and T7. The towel fixes T7. Can you twist that way? Remember, so I'm going to come around this way now. Can I get you to sit back? Look at the distance between the couch and me. So I will get them as far back as I can. Remember, they come to me, I never go to them. Obviously, because we have shorter legs for some, you can put a bolster under the knee. Ladies, some of you are taller, then you'd probably find it's not really an issue. So find the level you want to manipulate. To start, it's easier to treat this area than it is to treat this area or to treat this area. So for ease of learning, let's try around T6, 7, or 8, okay, for the first one. After, we will do below it. After, we will do above it. Okay, but for the first one, which is a little easier to understand, we will focus on this area. And also, we're not really going to cause too much of an issue if we don't quite get the technique. All right? Now, you okay for me to do it? Mm-hmm. So with a patient, verbally, okay, maybe get them to sign something. Are you okay for me to perform a spinal manipulation to that level of your spine? Yes, I'm happy for you to do it. They've consented. The chances of them causing an issue when they consented will be less than it would be if it was just verbal. I didn't say it. You wrote, you signed, you said yeah, yes. Okay, and you might have to mention that for the odd patient, they might have extra symptoms as a result of the technique. It's like seeing a surgeon, there's a chance of death. Okay, he's also said it. Okay, but I'm not saying there's a chance of death, but there's a chance of an irritation here because we are within the field, okay, all of us are in the same field. It's a mobilizing field. But in the corner, there's a little field. And that little field is a manipulative field. The chiropractors are in there in abundance. Some osteopaths are in there because not all osteopaths manipulate. And some physios, but not many, because it's not part of a normal course. We have to do a postgrad sort of course. And then you get the odd sports therapist, but not many. So that would be the minimum, okay, would be in there. Some of you might already be approaching it because you're already doing some techniques. So you have a choice now, okay? There's a gate. You come to the gate, you look in going, I'm not sure if I want to put my dipped my toes in that field yet and bring them back out. Going, I'm not sure. It's a bit scary. Okay, so again, but some of you might want to open the gate and just run in. Okay, I want to be in there. I want to be in the manipulative field. Okay, so as I said, it's a choice. Now, when I show you this, it is a ladder climbing. So the first one is the couch height. Number 2 is to sit them back. Obviously, before we get there, we would have done the assessment, okay, and the symptoms, etc., etc. Now, and then from there, the application of a towel, like number 4. I position my patient with the arms across this, will be number 5. I then find my positioning, number 6. I guide them into flexion, number 7. I might say to her, breathe in, breathe out, number 8, okay? And then as I'm doing it, I tension, so I pull with my arms and I push with my chest. So I basically push T7 anterior whilst I pull T6 posterior. So it's almost like an AP, anterior to posterior, or posterior to anterior glide. So when we're in that position, then obviously the finale, the icing on the cake, when you make a carrot cake, it's I put a carrot at the end. Okay, we can't put a carrot if there's no cake. Okay, so we have to do it in stages. And then if they're happy and you are happy, breathe in, breathe out. The technique would be a quick pull and push. So I'll show it to you, but I can only show it to you once. Because if it cavitates once, it's done. It's me finished and it's cavitated. Okay, so I can show you again, but I'd have to use somebody else. Yep. Okay, so so when I show you and I'll perform it, the technique will be very fast and I'm open for a cavitation. If there's no cavitation, I'll do the technique again. Okay, but the second time I'd use a little bit more pressure. If it goes on the second time, that's me done. If it doesn't go on the second time, that's also me done. Because I don't do it the third or fourth or fifth, because now I'm irritated. Okay, so once or twice, it's done. And I try to do a gentle approach on the first one. And if there's no release, I do a second one. If there's no release, that's it. Okay, I might go below it and above it, but I don't force it. I never force. The reason why patients are in more pain the next day or the week after is because the joint's been forced. Okay? Most of my patients are open, but the next day when I wake up, they're not in more pain. Hopefully they'll be in less pain. So, let's run through that. Everybody okay? Bit nervous? Me too. Not quite. Okay, so find, for the woman with a bra strap, find the inferior angle, come across that sort of T6, T7 area. If you can't see, come around. So place, so the sternum towel, I'm going to drop down to that sort of level there, okay? It's probably a little bit low the couch, but I can adapt. My left leg is back, my right leg is forward. Why? Because when I'm pulling, I pivot on my back leg, okay? If my legs were straight, I'll be arching my back and I'll probably irritate my own back. So that's where we are setting up. If you understand the basics, then we can move on from there, okay? But you have to get this right to start with. So drop down to that level. You okay there? This is my preferred way. Right arm goes under the left, not that it matters. And I pull my patient's arms to the back of their shoulders in here. Be careful where your hands go, okay? Onto the elbow of one. The other one, you guide her down into flexion until you feel tension in the sternum. Not for when they feel tension, it's when you feel tension in your sternum, okay, from the towel. So this is the position now. So now the other hand on the other elbow. From here, I'm going to slowly pull and push. Okay, so I pull with the arms to me and I push with my sternum forward. So I'm causing T7 to go anterior, T6 to come posterior. So that's where we are in that position. Okay, from here we have a choice. Take a breath in, please. I'm not going to do it. Okay, take a breath in. And as she breathes out, always on the out breath, I pull and I push and I lock and I would perform the thrust. I'm not ready yet. Okay, and I would perform the thrust to do it from there. So these are the setting up procedures. Okay, so the 1 to the 9. Now I'm going to do it. She's already given me permission to. So now I'm going to set up, breathe in, breathe out, lock, then I'll do the technique. Hopefully there'll be a cavitation. Okay, but as if it's not, I'll do it again. And if it's not again, I'll try a different level. Okay, but I never will force it. So from here, let's run through. So again, I drop down to that level. I'm going to get you to sit. Okay, so we sit in neutral. Right arm is my preferred way, not really matters. And I pull it tight. See, I pull it tight to increase the lever to that area. This hand on one elbow. I'm not on the elbow yet because I want to guide it down to the level. From here. Fine tune yourself. Okay, from here. So my left leg is pivoting. This hand on here. And I'm locking in there. Take a small breath. And as she breathes out, tension, 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 thrust, cavitation, and relax. Okay? All right?
Yeah, fine.
So what you didn't hear was the patient exhaling quite forcibly. Okay, if you turn around, so there was no response from the patient, which is what I wanted. If you face that way, if you come back towards me again, I'm not going to use the towel. So what you might think you see me do, okay, from here is, I apologize for this, okay? It's not uncomfortable as such, but it's not the same. So what you think you see me do, my hands are here, okay? And then as I do the technique, you think you see me do, okay? Do you have the out breath? Okay, it's uncomfortable for her. Okay, she don't like it. Okay, it's not very nice. Okay, so you don't, it has to be a pleasurable experience, if you like. If it's forceful and it's painful, they won't come back. Okay, they won't. And why would they? Okay, you're irritating them. The second thing you might see me do, the second thing, you're not going to like this one. Okay, from there. Okay, sorry. That's what I mean, but you might see me do that. You think the elbows are forced down into the chest. Okay, it's not very nice. It's almost like a Heimlich under. Okay, sorry. Yeah.
What was the angle then?
That's what I mean. So now the third one would be the way I would do it, from here, from there. Breathe in, breathe out. And as she breathes out, lock. Okay, not this, towards. But it's more push as I pull. Yeah. Okay, it's more push as I pull. Any questions? Because you can have a go. Okay. Yeah. So if you're not sure, I'll watch and guide you. Yeah, you all right?
Yeah,
Yeah. So if there's towels, grab a towel. If you're not sure, I will show you and guide you. I don't really want to do it for you. There should be enough. There's 10 towels. Have you got a towel?
We're going to do 6, 7, 8 area, are we?
Bit low couch. It's a bit low for you because you're taller. Yeah, so you probably need to go on a higher couch if you're doing. Yeah. Yeah. Yeah, be careful on yours. Yeah, so that I probably wouldn't let people randomly just do it. No. Yeah, yeah. But you can obviously, yeah, you can do it.
Right,
Yeah. Yeah.
where are you putting the towel for you?
Yeah. Because obviously for a woman it's.
I know, especially.
Yeah.
Yeah.
I'm not sure. I'd probably come under, push up.
Underneath.
Up, yeah, there, like that. Yeah, you'll be okay. Or go above on the chest. Yeah. That's what I mean.
Yeah, I
It's.
suppose you would have to
I will show you other techniques because for a woman who's got maybe big,
Yeah.
big, then it's harder. Yeah,
harder for them to do it.
harder for them to do it. Yes, because there's too much softness. Yeah, especially if it falls. Yeah,
Right.
yeah.
Right. So your back. Move back as far as you can. Place the neck here.
How's that?
You are
Yeah, probably a little bit faster. A little bit, yeah, a little faster. Yeah, yeah. Yeah, look comfortable. It look good. It look good. That's what I mean. The 1 to 9 is quite straightforward. It's the finale, if you know what I mean. The execution is where people naturally struggle with. And he's quite a big guy as well, so it's not easy to get around him. And he looks a bit stiff.
So I should.
Okay, and the towels look way too soft. Look, way too soft. Okay, so fold it in a different way. Fold it, and as tight as you can get it. Yeah,
Right.
try that. That's a lot firmer. Okay, see what you think. I like his tattoo.
Oh, that's cool. It's almost
Yeah,
like 3D.
that's Medusa and the lion, isn't it? Is that Medusa?
It's cool. It almost looks
Yeah.
3D.
Is that Medusa on your and with a lion? Is that Medusa?
Yeah.
Yeah, because I had a lion, don't I?
All right.
Yeah, but I'm gonna have a Medusa there.
Oh,
or
on
something.
the other side.
I'll show you variations. So this is the first one. So just So because let's change his arms. So let's go right under, hold on the back of his shoulders, one hand on the elbow, flex him down to the level, hand on this elbow. Okay. Now I'll guide you. Okay. So both of you take a breath in, and as he breathes out, you pull with your hands, push with your chest, and you cause tension. When you're ready, you then thrust from there. Yeah. So try again. Breathe in. So you pull first, you push first, you lock, then you thrust. Faster. It's probably not that easy because he's bigger. Okay. Lock. Better, but still faster. Okay. Yeah. So it almost has to be a definitive from there. If you're not sure with him, there's a couple of ladies here. Yeah, you can maybe work with one of the ladies as well.
See if you can get it.
Yeah. So maybe feel a bit difference, okay? What was your first name? Oh, Doug, innit? Hold there, Doug. And there. So from there. So I'll bring him in, okay? It's already went. Okay, it went to squeeze him. Take a breath. Breathe out. Let go. Relax. Yeah. Okay? Yeah, because probably you're trying to squeeze. And the chest to draw is like where it seals, it has to be definitive separation. If you just pull in, it's like a tight bear hug. You know what I mean? So there has to be a try. He's not going to go now, so maybe try one of those goals. Yeah, and try again. Good luck for that.
I know,
Yeah. Interesting if you can get it. I'd be impressed if you can. Yeah.
It's just, I need to get it down.
And I think it's a bit softer towel, so I probably would change it the way you fold it. Fold, tight. As tight as you, honestly, as tight as you can get it. Don't use it all, just use half.
Okay.
Now try that. Okay, it might help you. Sometimes it does.
Yeah, I can see the difference.
Yeah.
I'll try it again.
Cross hands. Okay, chin to chest. Okay. Nice deep breath in.
Okay, pull first as you breathe out. Pull, push with your chest so you lock in. Then you do it first.
Okay.
You okay?
Yeah. So, yeah, chin to chest. So, into that position. Nice deep breath in. Breathing out.
Faster. Yeah, you're only squeezing. You're just using your strength to squeeze.
Okay.
Okay? It's not really about the strength of the therapist. It's about the technique of the therapist. And sometimes the petite woman is better than the stronger man because she has to rely on technique. Okay? Yeah. So like you just feel lock rather than strength to pull. Okay? Yeah. Try a bit lower because they're not easy where you were to 45s. It's quite rare to get that one there. How are we doing? So a bit lower. Was that?
Neither of us got.
Okay.
I think the bed was a bit low. Can I go through it with you?
Yeah, of course you can. Yeah. That's what I mean. So it's not that easy, but once it's just watch. That's okay. Yeah. So firmness. There has to be a firmness of the towel.
Yeah.
Yeah.
So tail's firm enough. So I'm going to come in there.
Yeah. It's okay. That's probably the easier ones to get.
Please.
So
Tail.
drop your sternum down to the level. That's okay.
Make it. You
Yeah.
to cross your arms across.
So right arm under left. Okay. And then one hand on the elbow. All right. Before you're on this one, so you guide it down to the level. A bit further. There.
Yeah.
Now this hand on the elbow. From there. Okay. So this is the position we're in. Okay. All right. I'll guide you through it. So both of you take a breath in. And as you breathe out, you start pulling, Jerry, and start pushing with your chest. So you lock, and then you thrust. Okay, so we'll do it again. Okay, so it'll be like this. Okay, so you breathe in. As she breathes out, and you pull, you push, thrust. Okay, it can't be a chest to draw in and hope for the best. You pull, bind, thrust. Okay, let's try again. Breathe in. Breathe out. Push, pull, lock, thrust. You're trying to separate your arms, but it's not bad though. Okay, that was not bad.
Okay.
Yeah. Okay, so just a little faster. Yeah. How are we doing? Yeah. Yeah. Oh, well done. Well done, see? Yeah? Yeah. How are we doing, Kelsey?
Not the last bit.
Oh,
It's like I want to pull out of it when you that last.
yeah. So place that wherever is more comfortable for you, above or below.
Yeah, that would be better there.
Yeah. I think for a woman you have to adapt. Yeah. Sometimes it's probably still a little borderline tender, where the towel is for a woman. Yeah.
Right, so you there.
That's it. Good.
Forward.
Good. So from here, it'd be like both of you will take a breath in, and as she breathes out, you will pull, you will push with your sternum, so you lock. Okay, so chest will lock, and then from there you do it first, but don't do it yet. Okay, and then you can do it again. So take a breath in, and as she breathes out, you pull, you push, you lock, you thrust.
Right.
Yeah. Okay, so it's almost like breathe in, breathe out.
It's the last bit that I've.
Of course, and that's what I can teach you. I can show you and do it and guide you, but I can't do it for you.
So I'm doing the right movement. It's just doing that
So
last.
the 1 to 9 is fine. It's the 9 to 10 that most people would need to work on. Yeah. Okay. Try again.
I'm quite happy for you. We've been doing this for a while. Right. So
That's
heads
it.
down.
Yeah. So both breathe in, and as she breathes out, you pull, you push, you lock, thrust. You trying to just squeeze it in
Yeah.
tight.
I can't do it.
Yeah, you can do it. You just have to adapt yourself to it. Just try it when you squeeze. Just save a little bit of a.
Yeah, like that. Yes.
Yeah. Yeah.
Oh, I don't have the chest for that.
Yeah. But rather than just using your chest,
Use that.
half and half. Okay,
Right.
half on your hands to pull, push. Okay. Breathe in, breathe out, pull, tension, lock, thrust. Okay, you're trying to squeeze it. Okay, you're trying to. Yeah. Can I just show you again? Anybody struggling? How did you two get on?
I didn't get Jerry. I didn't get a card.
Okay. Can I just show you, Jerry, come and sit here. So let me just show you again, okay? Yeah, because most of you are getting it. It's the 9 to 10 most people struggle with rather than the 1 to 9, okay? So, let's come back a bit. So the towel needs to be tight. As tight as you can get it. Okay, so I'll run through this one a little quicker. Okay, so some of you are going a bit too high and it's hard to get T4, 5. So stick around T6, 7 or 8 for this one, because after lunch we'll do T9, 10, then we'll do the C7, T1. So from here, apply the towel. Okay, so couch is a bit higher than the other one, but I can adapt. Pull tight, hold, hand, slump, down. Okay, so the chest to draw, you pull, feel the bind, and it's the pull and push from there. Hold, okay? Take a breath. Breathe out, pull, lock, thrust. Okay, and then a cavitation. Yeah, and then no from the patient. Yeah, because if they're irritated, the chance of them coming back the following week, it's close to 0. All right, so it has to be pleasantly, manipulation is sort of pleasantly unpleasant. Yeah, it's the one of those like, oh my God, I'm so nervous. Yeah. Okay, so, but like for instance, if you just turn, I'm going to show you this one. You can try this if you want to. If you are, give or take the same height within an inch or two, okay, that's fine. If they're about 4, 5, or 6 taller and they're heavier and bigger, then it's a little bit unrealistic to do that, okay? But let me just show you this one, okay? Because you could, and it's up to you whether you want to try it or not, it's your choice. Find the same area, same technique, okay, from here. Right arm under left, no difference. Hold. Guide the patient down. The difference now is, excuse my hand, okay, because you need permission. Hand is on the ASIS for my patient. And then from there, I want you, if you can, just to let your body just drop down, okay? For a woman, it's probably, they seem to relax more than a man, okay? Not many men just relax. That's why I normally choose a woman for this, okay, where they just relax down. My right leg is there, so she feels the weight, okay? She's not going to go forward and she feels supported from this position. The key is they fall back as they breathe out and you do the technique. So as they fall, you do it. Watch now, take a breath. As she breathes out, fall, thrust. Relax, okay? Okay, as they fall, so you assist the body weight fall in, helps you a little bit. It's all about the timing on that one. Okay, most people thrust just before they fall back or fall forward so as they fall, you lift a little, okay? Thank you. Thank you. Okay, so just a couple of minutes. Have a little swap.
Head still when you're doing your first
Yeah.
step forward.
Do you want me to fall into you?
Yeah. Yeah. For my row, as you were taller, I'd use a step because it'd be like 6'5". Yeah. To fall back. Yeah. Yeah. But you can try.
I've done.
Once you get a minute,
Of course.
just
Done.
Yeah. Of course I will. Yeah.
You ready?
Of course.
I always prefer to wait like 1 or 2 seconds when it's breathing out.
Fine.
1, 2.
Yeah.
After thrust.
Me too. Breathe in. Breathe out. Yeah.
So I'd almost be like down lower than.
Well, I guess because for obvious reasons.
Yeah.
Yeah. That's okay. So right under, hold. Yeah. Right. So one hand on the elbow, one hand guides her down to the level. Okay. This hand now comes onto the other elbow.
Yep.
Okay. So the technique from there, you are fine. I think you are a bit low, but we'll go through it anyway. Okay. It's probably just the application of a towel here. So just have a go. Take a breath in, both of you. And as she breathes out, you initiate the pulling and you initiate the pushing with your chest. Okay, so you increase tension down to that level. Okay. And then, so this would be the 0 to 1 stage or 9 stage, and it's the 9 to 10. Okay, that's where people will struggle in. Take a breath in. And as she breathes out now, you pull and you push and you lock and you thrust. Faster.
Faster. So
Faster. Okay.
Yeah, it does.
Yeah.
Just want cough at the same time.
Yeah. So breathe in. Breathe out. Pull, push, lock, thrust. Better, but faster. Yeah. Okay. It shouldn't feel too. Some people, when they feel in your chest, you're almost doing too much of a push in. It's almost like I try not to do that. I almost like there. Yeah. Okay. So that's where the skill is that
It's not like
the
that, but
tiny little last bit, the 1/10 of the 10.
and like,
Yeah.
so that's
And it
under the label on our sternum.
sternum. So you have it coming below your breast or above it. Okay. So you come below and
I
up.
was on it.
Yeah, I know you were. Yeah. Yeah.
Okay.
Yeah. Yeah. But it simply defines whether it's a manip or mob. Yeah. Okay. Because if you squeeze in and just pull in, it's more of a grid 4 mob, whereas if you thrust in, it's a grid 5 mob. Yeah. For you terms. Okay. Take a breath. And as she breathes out.
So,
Yeah.
so what do you have to?
Yeah. That's it. So breathe in. And as she breathes out, you pull, you push, you lock, you thrust. There you go. Yes. High five. Well done. Well done. Well done. Everybody okay?
Yeah.
Yeah.
It's a little bit of a difficult one to do that, isn't it? Depending on the size. Of the
Depend. It does depend on your patients. Easier. Potentially, it's easier. Yeah. Yeah. Not bad, Evelyn. Not bad. Yeah. There is a definitive thrust. Okay. But everybody's apprehensive about the thrust. How much? And it's hard to say how much do I do because it'll be different from you. From you know what I mean? Yeah. But I always say start gentle and increase rather than start high and bring down. Yeah. But it's interesting watching people now because as your techniques go on, you look and go, will it or not? What's a technique like? Is it similar to mine or not? Yeah. Good. Like she's keeping the hips forward, so she's not letting the hip drop back. So she's staying in extension, see? Yeah, it's just having the confidence to, there you go. Well done, Evelyn. Well done. Well done. Yeah. So Evelyn, you might find that one easier. Yeah. 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 Because there's another lever to it because you allow them to fall. And as they fall on the towel, it's causing like a lifting. Yeah. It's what boobage. Yeah. I was going to say that.
I definitely felt you falling like when I tried it.
Okay, well done. Yeah. So 45 minutes for lunch. So as long as we start back about 1:30, it's fine.